It is in many ways very appropriate that you have a British psychiatrist talking to you today about community psychiatry in Denmark. Because historically, we have a rather sad link. That in 1807, in the Second Battle of Copenhagen, not Nelson, but his successor, bombarded your beautiful city for something like 14 days and killed several thousand people. I'm very sorry. But one of the consequences of that was that the shells broke down the walls of the asylum and all the patients got out. So I assume that community psychiatry started then in Denmark. I'm the most boring bit of your conference because I'm the academic and I'm going to talk about facts and figures, and like all academics, I am going to be deliberately sceptical. It is my job not to trust things until we check them out. And I'm really going to be focusing on how we distinguish what we know from what we believe. And I would suggest to you that that is extremely important in our business. There is probably no branch of medicine which is more susceptible to fads and fashions and ideologies than mental health. And that's partly because the disorders we deal with fluctuate, so it's quite hard to see an immediate result. The illnesses often go over long times. And secondly, because whatever else there are, mental illnesses are social disorders. They're experienced and expressed in social conditions. And I'm going to suggest to you that they are treated in relationships. Now, one of the things that I think is important about this research, and it's going to focus, as Matt mentioned earlier on structures of care, partly because that's easy to research. But while we do that, and I'm going to do that, and I'm going to focus on these facts and figures, we mustn't forget the important thing, is that structures of care never got anybody better. No team ever cured a patient. It's you and your treatment that cure patients. So when you look at the evidence about structures of care, and you think about structures of care, the only thing that matters is, does this structure of care help me establish and sustain a trusting, effective, therapeutic relationship with my patient so that they can get better? And that should always be your benchmark. Don't be seduced by the complexity of it or the elegance of it. The research is important, and I would suggest the research is very important to us. We can take some pride. I'm going to talk about the very scientific approach to research. That psychiatry was the first branch of medicine that ever used a randomized controlled trial to prove that a treatment was ineffective and abandon it. It wasn't rheumatology, it wasn't oncology, it was us. It was our randomized controlled trial of insulin coma treatment that stopped that ineffective and hazardous treatment. So rigorous scientific methodology has a lot to offer us. Having said that, we need to be very careful in how we interpret it. I'm going to suggest to you two things before I start fully. That the research tends to be exaggerated in its effects. There are differences between these different services, but they're relatively modest. And we need to think hard, just like the example about Moldova. Is it worth changing for what is often an important but modest change if it causes disruption? So you need to be sceptical and think about that. But the second thing to say is that the research, for all its messiness and for all the time we've spent on it, has, I think, genuinely taught us things about how best to deliver integrated community mental health care that we probably could not have learnt without the research. So the research, I think, is a crucial part of how we improve our practice. And I'm going to suggest that in understanding assertive community treatment or mobile teams or outreach teams, I think the terms are not as distinct as people say they are. They overlap enormously. If we want to understand it, the history of it really divides into two quite distinct phases. There's the phase up to about 1980, and there's from 1980s onwards. And And the phase up until 1980 was essentially organic evolution in response to the closing of the mental hospitals. As mental hospitals started to close, psychiatrists, psychiatric nurses, social workers started to work together in teams, not particularly for ideological reasons, but because the patients they were now dealing with were really very ill and had complex needs, and the only way to look after them outside a hospital was to form some sort of effective team. And so from about 1960 onwards, you can see in Europe the development of community mental health teams, which are basically multidisciplinary teams, doctors, nurses, social workers, sometimes psychologists, sometimes occupational therapists, working together to provide comprehensive care for their patients. And that development, as I say, was driven by the clinicians, but usually without any science. It was basically what seemed to work. And the three countries in Europe that tend to be associated with it were France and England, who really got it going in the early 1960s. And I suppose England have stayed with it because we have an NHS system ever since, and we really have majored on these mental health teams. So, for instance, we started having nurses who were visiting patients at home as the almost exclusive part of their job right back in 1953, and by 1970 they were the backbone of our service. France was a bit more intellectual, and then later, about 1978, I'm sure you're going to hear from Roberto about Law 180 and the developments in Trieste, the Italians came on the scene, and as always, the Italians did it better. They did it with more glamour, they had better food, better clothes, and they made it work in a much more jazzy way. But basically, for the first 20 years, this slow development driven by clinicians. Now, I think it changed around 1980. It's a bit artificial where you take it. But essentially, that's a bit about what the teams were like. The change, I would suggest to you, came, and it is at least benchmarked by the very famous publication by Stein and Test. They published 3 papers in 1980 in Archives of General Psychiatry, in which they described their study. Now, their study had a big impact, partially because it came at the right time. That basically throughout the 1970s, there was the growth of evidence-based medicine. Now, I think you all know that, you're all schooled in it, that's how all of us live most of our professional lives. That's to say, we expect to determine our practice by reading the best scientific evidence, not just by doing what our teacher told us. So there was this period of replacing, if you want, clinical authority with evidence, and that was throughout medicine. But it wasn't really until about 1980 that it got to what I would call mental health services research. That's to say, the scientific investigation of the structure of care. And evidence-based medicine has two very important impacts. The first is that it challenges established orthodoxy. It allows you to challenge what you've been taught and learned. And it not only allows you, it requires you to test what you've been taught. Second impact is that it internationalises practice. Although Moldova may be different to England, may be different to Denmark, they're nowhere near as different as they were 40 or 50 years ago. When I worked in South London, if you walked from one ward to the next, you were in a completely different practice. Now at least we're generally following an accepted body of evidence. So there's an internationalisation of it. So let's look at this Stein and Test paper, because it's relevant to this concept of assertive community treatment. Now, a little historical and less known fact is that the 3 big studies that are always cited as being the origins of assertive community treatment, Stein and Test, John Holt, and Bob Rosenheck in the VA in America, none of them called it assertive community treatment until later. So it's quite interesting that this is a post hoc concept. But basically what Stein and Test did, they did a small, opportunistic, randomised controlled trial, 126 patients, 62 in one arm, 64 in the other arm, and half of them got service as usual. They were discharged from Mendota Mental Hospital in Madison, Wisconsin, and disappeared until they came back. And the other half got intensive case management of a form that evolved under Len Stein's and Mary Ann Test, who's a social worker who I think was very important in this and is often overlooked, understanding of how best to provide care for chronic psychosis. Now, what they found a number of things, but what's important and why it became internationally famous, they found two things. First, they found the impact was enormous. They reduced hospitalisation by over 70%. And they improved social functioning and employment. Symptoms are about the same, and costs are about the same, or less or more, depending on how you measure it. But basically, to reduce hospitalisation, that's enormous, really. So this had the first reason it had an impact was it had an enormous effect. Very few modern research studies have an effect size anything like this. In most of medicine, most of psychiatry, if you get an effect size of 15 or 20%, you're doing very well. 70% was enormous. The second reason it was so influential was that, unusual for the time, they described their practice. There was 2 paragraphs in the paper that said what they did. So when you read the paper and you saw the effect, you can actually also read what they did. And they described their team, and they called it the Programme for Assertive Community Treatment. And the first and the most striking one, the one that's always quoted, is very small caseloads. Each full-time worker had only 10 patients. So that's a full-time workload, just 10 patients, and they visited them once a week to once a day. They also went out to visit patients, rather than waiting for the patients to come to them in the clinic. I think that was the most important thing they did, personally. Interestingly, they did it for all the wrong reasons, but it was the right thing to do. And they also set up daily meetings, and they worked in a very multidisciplinary way, and they had this emphasis on what they called a whole team approach, which is the patient should be treated by everyone in the team. Now, again, one interesting thing is, if you look historically, the reason they went home to people was not to do with why most of us go home to people, because we know our very ill psychotic patients won't come to us. It makes sense to go to them. They did it because Len Stein was concerned with the transfer of learning in schizophrenia. He thought that you couldn't teach social living skills in a hospital and then transfer it out. You had to teach it there. So it was the wrong reason, but the right response. The whole treatment approach, perhaps I shouldn't go into it too much, but he thought, he used to still believe, he was a trained analyst, he believed that pathological dependent relationships were one of the causes of schizophrenia, and that the way to help people get better was not to have pathological dependent relationships, and the way to do that was not to have dependent relationships. In my view, completely flawed thinking, but what it was a multidisciplinary approach. And interestingly, when I went to visit his team, they didn't do it, but they didn't tell him. They got on with their job in a sensible way. The thing that people often overlook, and it was 24 hours a day, 7 days a week. So you knew what it was, 1 to 10, regular visits, going home to people, 24/7, and this whole team approach. What was also in the paper, which is always overlooked, is it had a clear and persistent focus on getting the patient to take their antipsychotic medication. And probably that was one of the important things. So here was, if you want, the starting pistol for evidence-based medicine. And the result, it was enormous. By 1998, in 1980, there were only 8 community mental health studies published. By 1998, when Tim Muser did his review, he could find over 50, of which 30 were ACT type. And when Joss Catty and I did our review in 2002, we found over 90, of which 60 were ACT-like. So this is probably one of the most researched mental health service structures that exists. So it's an enormous research base. It isn't replicated anywhere else. You won't find an evidence base like this for day hospitals or crisis teams. This is an enormous evidence base. And one of the things that, of course, happens when you get a good enough evidence base is that you can start to draw overarching conclusions. And this is a forest plot, which I have to show you, which I think you're all familiar with, which is where you add all the studies up, and if you've got enough data, you can do that in a reliable way, and then you can draw a conclusion. So this is basically the effect. This is the effect, and these are the confidence intervals. So basically, you add all these up and how big they are, depends on how many patients, and you get a final result which adds these all up. And this tells you the effect size of ACT on hospital admissions, and if it doesn't touch that line, this little lozenge doesn't touch the line, that means that the aggregated difference is statistically significant. And what you see here is a clear statement that taking these 6 studies together of ACT, they reduce hospitalisation. And this was published in 1999, a Cochrane review by Marshall and Lockwood. I see it in your reference list. And they published at the same time a similar analysis of the results of case management. Well, maybe it's fair to do it for you over here, of case management. And what you see here is that in these 6 case management studies, that the combined effect lies clearly to the right of the line and doesn't touch the line. So what they showed was that case management actually increases hospitalisation, assertive community treatment reduces hospitalisation. So that's a very clear result, and it's a triumph of evidence-based medicine. You've done all these research studies, you've added them together, you've tried to see what you can draw from them. And the result of this was certainly very powerful in the UK. Our government decided that this was such powerful evidence that we had to reorganise our services right away. And they mandated, they required us to establish 300 such teams. I ran one of these teams for 10 years, although I started it before then. So that we spread them throughout the country. And here's a shameless advert. We even produced manuals on how to do it, and this is a very good one. I highly recommend this. Burns and Fern. You can get it in English or you can get it in Swedish. It's worth every penny, or every krona. So basically there was a sort of a tremendous sort of buzz around the fact that we were beginning to design our services around international evidence. And in many ways that's a wonderful thing. It's psychiatry, if you want, coming out of the dark ages, not being hocus pocus, being a more scientific discipline, choosing how to provide services that should work. But there was a problem. The problem is that just as we were doing it, 2 enormous studies came out. In the UK, it just happens to be, one called the UK 700 study, which was 700 psychotic patients followed up in 4 sites for 2 years, and the other was a PRISM study, which is about 550 patients studied by Graham Thornycroft and his team in the Maudsley, and neither of these studies found an advantage. So just as we were having the government initiative saying you must do this because it's going to save hospitalisation, 2 very rigorously, slightly different studies, one very rigorous, the other much more epidemiological and somehow perhaps more generalisable, neither of them found a difference. And also, I have to say, nobody has ever found a difference in this outcome for assertive community treatment in any European study since. Any European study that's of high quality, that meets the quality standards that would get into a Cochrane review. So this isn't an odd finding. It felt it at the time, I have to tell you. We were really, I mean, I'd worked for 4 years on this study. I was devastated. I was running a team. I was telling everyone how wonderful it was. Bang! The evidence is it didn't make any difference. So actually, you have to think again. And this is a lovely quote from John Maynard Keynes, you know, the economist. You mentioned economy, Matt, so economy is important. John Maynard Keynes was criticised at the Bretton Woods conference after World War II for giving different advice to America and Europe on how to rebuild their economy after World War II than he'd given in the 1930s. And somebody came up to him and said, you know, I think it was an American who said, you know, Maynard Keynes, you're giving us different advice. You've changed your mind. And he was a very pompous man, very tall and pompous. And he drew himself up and said, when the facts change, I change my opinion. What, sir, do you do? And I think this evidence means that we ought to have the courage to rethink what we believed. Now, 2 explanations were knocking around. One was that either European standard care was so different to Australian and American in the sense that it was already achieving many of the things that ACT would achieve, so that our bed usage would be about the same. And the other, very understandable and vigorously proposed, particularly by the Australians, was that we in England were so rubbish, we couldn't get anything right, and therefore it wasn't surprising that we didn't find a difference. So that's what's called poor model fidelity. That's to say, our ACT teams weren't real ACT teams. And you can argue and argue and argue about it. That's what science is so useful to us, because it means that instead of getting huffy and puffy about it and arguing and being sort of holier than thou, you can actually test it. So we did test it, and along with Max Marshall, we conducted something called a meta-regression. Now, meta-regression is a very complex statistical technique. It's a bit like the meta-analyses I've shown you, but it's much more powerful. And we did this meta-regression because it allows you to divide multi-site studies into different sites. But we also got, from the studies that we put into this, we got an estimate of model fidelity in all of them by writing to the people who conducted them, or by examining the papers if they were good enough. So basically, we were going to test why, after 15 years of evidence, these two big studies in the UK had failed to find a difference and nobody else was. Could we learn anything from it about the right way to do community care by examining the evidence we've got? And actually, we got some very interesting answers. The first is that we did confirm that one of the main reasons that we were not finding a difference in the UK, and also the Germans found the same results, one study by Rössler before he moved to Switzerland, is that our use of beds, our normal community care was such that people with psychotic illnesses did not spend long times in mental hospitals. And essentially what this shows is that here you've got what's called the intervention effect. That's to say, the difference between the asserted community treatment and the other normal care. And if it goes down here, that means that asserted community treatment is reducing the number of days the patient spends in hospital. And these are the number of days per month. Along the bottom, we have, and each of these blobs is a different site in a research study. The bigger the blob, the more patients. And along the bottom, we plotted the number of days per year most people in that service, i.e. the control service, spent in hospital. And what you see here is, I think, an unequivocal demonstration that an enormous effect is due to how long you stay in hospital. So, if your normal patient stays in hospital 15 days out of every month, 6 months a year, then you can reduce that by 5 days a month, you can reduce it by 30 or 40 days. But if your services routinely tend to keep your psychotic patients in hospital for 2 or 3 days a month, 30 days a year, equivalent to one relapse every 2 years, 60 days, then actually there's no difference. And that, if you look at the UK 700 and most European studies, they're up here. So it confirms that, to some extent, the enormous reduction that Stein and Test and Houghton people found was because their studies were out here. But that isn't helpful to you, unless you're out here. And most of Europe is in here. So the first lesson to draw from this is that the effect you could expect is very dependent on what your normal practice is. But we were able to go a bit further. As I say, we measured model fidelity. That is to say, what was the assertive community team in the study doing? And we did this by writing to all the researchers, or by examining what they published, and you can do it. And we used a scale, there are a number of these scales of ACT, I can't remember what I stands for, but F is fidelity, impact of fidelity, ACT, something like that. So basically 14 questions that you could set to the program, and you could say, is it high fidelity? That means, is it very similar to what Stein and Test did, or is it actually not very like them? And one of the good things about the I-Fact is not only does it give you an overall score, but it has 2 factors in it. So you can start now to tease out, if there is a difference, what's causing it. Because the IFACT allows you to look at organisational features, and it allows you to look at staffing features. And here's what we found. Well, it does indicate that the Australians may have been right, that if this is the same as you saw before, only upside down for certain reasons. Basically, this is how faithful you are to the Stein and Test model. So if you're up here, that means you've got a very faithful model. If you're down here, you'll hardly like it. This here is the effect size, how much you reduce hospitalisation as you go up. And that shows you that if you are more and more like the sort of described teams that we wrote about in our book and Len Stein wrote about, the more you're like that, the more you're going to reduce hospitalisation. So there is an effect on the quality of replication of the study. So that's an important finding. But, as I say, IFACT allows you to distinguish organisation. Organisation means things like, do you do home visits, do you have multiple meetings, things like that. How often does your team meet? And what you find here is if you just take that part of the scale, that you also find this strong correlation, i.e. this seems to be at least as strong as the overall correlation. Okay? So that if you have the organisational features of ACT, then you reduce hospitalisation. What about the staffing? Because bear in mind that the most radical component of introducing ACT, certainly in England, was having to deal with the staffing requirements. Caseload size of 1 to 10, specific members of the team, such as vocational counsellors, dual diagnosis workers. What does that show us on this? Well, actually, it shows us unequivocally it doesn't make any difference at all. Now, that's a good pause to think. That ought to be optimistic. It means that if you're working within a restricted budget, we're all working within a restricted budget. Your budget may be bigger than our budget, but it's still restricted. That actually you can probably deliver equally good care without spending quite as much money as the original service suggested. So to some extent, that's told us that what you don't need to do. You don't need to have all these very fancy extra people in the team, and you probably don't need to have very small caseloads. But that doesn't get us very far in terms of what do you need, what does make a difference. Now this is a study that we did around a bit later than that. We did it earlier than the British Medical Journal study I've just shown you. It's nowhere near as scientific, so there's a bit of a health warning with this. Take this one with a little bit of a pinch of salt. The other one I think is hard science. I don't think you can really argue with that finding. This one is a little less secure, but I don't think it's bad. What we did on this one is we did a systematic review of home treatment services, and we cast the net wide. We didn't say just ACT, because we'd already learned that the distinction was very, very fuzzy. And we wrote, remember we found 90 studies, we wrote to all 90 of the people who conducted those studies, and we got answers from 60 from all over the world, so not a bad response rate. And what we did before we wrote to them is we got a bunch of experts in, and we said, we're going to write to these people. We want to try and identify what matters in good integrated community mental health care. We don't want to be ideologically driven. We don't want you to say, Stein and Test said this, therefore it must be that. We say, you who've all worked in this area and you've researched in it, tell us what your impressions are of the things that seem to matter. And this is the crucial bit, and that we can essentially get people to answer yes, no, or at the very most partial. So what we did is we got 20 characteristics out of this expert body. We put them in a questionnaire and we sent it to them and we said, tell us what was going on in your experimental team, forget the control team, in your experimental team while you were doing your study. And we gave them the 20 things and they were to tick whether they were happening or whether they were fully operationalised or not at all. And I say 60 of them sent back to us. And they gave us essentially 6 components, if you want, that regularly came up. Now that's interesting because that means 14 components didn't regularly come up. So of the 20 we got, 6 seemed to be regular features. And let me take you through them. Forget the lines joining them, that's to do with a cluster association. Smaller caseloads at the top. Smaller here was defined as 1 to 20, not 1 to 10, 1 to 20, right? Smaller caseloads. Regularly visiting at home. Now you may think that this is done twice because it says high number of contacts at home and regularly visiting at home. There's a distinction here. This is a policy practice component of the team. The team has a policy to regularly visit people at home, not just for emergencies, but as part of their day-to-day practice. Yes, no. This one was a quantitative estimate. We gave them 25%, 50%, 70%, 75%. What proportion of your contacts with patients are at home? And this is high proportion, 70% plus. Okay? So those 3 factors seem to come up regularly. Multidisciplinary team came up regularly. Multidisciplinary here was defined in a very simple way, because again, and Matt will be able to tell you more about this than me, wherever you go, the composition of teams varies a lot. In England, the backbone is doctors and nurses. In America, it's not doctors and nurses, it's doctors and social workers, or doctors and this or that. So they vary. But what multidisciplinary means here is 3 trained professionals or more who are a regular part of the team contributing their professional perspective. The other one was psychiatrist integrating the team. You can accuse us of being a bit preoccupied with ourselves, because a lot of the people were psychiatrists. We asked 2 questions about psychiatry. One is, because you can quantify it, how much psychiatric time did the team have? Because if you just say if there's 100 patients in the team, how many full-time equivalent psychiatrists were there? And people could work that out. And that didn't come up at all in our response. So the amount of psychiatric time did not seem to be a consistent feature. But the second question arose was, how does the psychiatrist operate in the team? Because we become aware of at least 2 quite distinct models. There was a model I saw in North America in which the psychiatrist was an expert that the team consulted with. If they were having difficulty with a patient and there was a psychopharmacological issue, they wanted the drugs reviewed and changed, they would get the psychiatrist to see them. And then there was the more common European one, in which the psychiatrist was an integrated member of the team and took part in all the decisions about patients, not just whether their medicines needed changing. I mean, he or she will probably have more to say about medicines, but they would sit in all the meetings, and we call that integrated psychiatric role. And that seemed to be important. And the other one, and I think this may be very relevant to some of the development you're having now in Denmark, as I understand it, is that it came up was the integration of health and social care within the team. Now, we define that in a very simple way, because integration of health and social care can mean some sort of grandiose statewide plan, or it can mean something actually in the day-to-day care of the patient. We basically said, can your team provide both medical treatment and social care from within the same group of people without there being any administrative hurdle to cross? You don't have to write a letter, you don't have to make a referral. Can the team deal with housing? Can it deal with money? Can it deal with clozapine? The same group of people. So that came up. Now, we then, and again, I do warn you that this is not great science, this is much, much more speculative. We then did a regression analysis of all 20 of the features against the reduction in hospitalisation. We wanted to see if any of them stood out as being more important or more effective in keeping people well. Because although we measure hospitalisation, the reason we measure hospitalisation is our assumption that the opposite of hospitalisation is that we are succeeding in keeping people well so that they can conduct their lives outside hospital. And 2 of them came up as much more important than the others and driving some of the change. And I wonder if you can think for a second which you think, I'm not going to ask you, but you might want to think which 2 do you think are going to be the most effective in keeping people well I'd guessed one, got the other one completely wrong. They're those two. I'd assumed regular visiting at home would be very, very important, and it is. But I hadn't actually realised that social care being integrated in the team was the other major factor. It's quite important. Now, it's unsure to me, I'm unclear why that is. You could argue, and it's a very strong argument, that if you're managing a severe mental illness over many years, that the treatments are only going to be particularly effective if you're helped to manage your social functioning. That to some extent, if you've got nowhere to sleep and you haven't got any money and you can't get the bus, then of course you're not going to get your drugs and you're going to become unwell. And I think that's a strong argument. I think there's another argument, which I suppose is a personal observation from having worked in these teams, is that I thought that social workers, more than any other member of the multidisciplinary team, were the ones who brought the different perspective. They formed a much more, they forced us to think much more holistically than because doctors and nurses tend to be fairly similar in what we think is the matter. And psychologists have often a much more specific technological approach. I think social workers force us to think much more broadly, much more from the patient's point of view. We don't know. But basically, there is a suggestion that these two features are probably the most important on the current balance of the evidence. So, I do apologise, it was so early in the morning to be giving you so many facts and figures, but they do teach us something. And they brought us somewhere that we would not have got. If we'd not done this research, we would all be just doing sign and test as if nothing had changed. Well, it's helped us distinguish some of the things that matter and some of the things that don't matter. I would suggest that we now know that if you want good, effective, integrated community mental health care, you need to have, particularly for your very ill patients, easy access to home visiting. Your psychiatrist needs to be part of the team, because we can't pretend the drugs aren't important. And if they're not utilised and prescribed and adjusted within a real rich understanding of what's going on, then I think the patients suffer. I think the message about combining health and social care is very clear, in my view, that you do need that. You need multidisciplinary working. There is no place, I would suggest, in the modern world for people with severe psychotic illnesses being treated by a psychiatrist working in a private office. Their needs are too great, they're too varied, we need a team to deal with them. We need probably small caseloads. That's to say, you need to be able to predict your workload, you need to be able to see people at least once, a couple of times a month. More than that when they're ill, but at least a couple of times a month. And the team organisation, having a proper multidisciplinary system that works, is important, although the specifics of the staffing isn't. But perhaps even slightly more important, we've learned some things that don't matter. And I would suggest to you this is the more important thing to learn. Tiny caseloads do not bring benefits. I would be prepared to argue that in any setting. How many of you have got a caseload of under 10? When I got my team started in 1993, and I said, okay guys, to all the great nurses, you're only going to have 12 patients. You're going to see them 3 times a week. They said, great, we're going to be able to do everything. A month later, they say, I don't know what to say to him. I saw him the day before yesterday. I'm seeing him more often than I see my wife. What are we going to talk about? I think, and then we talked about, listened to the patients. They said, if you've got schizophrenia, whatever else schizophrenia is, it makes you a shy, sensitive person. You don't want people bouncing through your door every day or two. So I think actually tiny caseloads are not indicated, and nor is ultra-high intensive contact, unless people are actively relapsing. So I think we've learned something important here. Highly specialised staff, great if you've got them, but there is no scientific reason for taking away well-functioning people doing other things to be that. So if you can add them, fine, but it's not a reason for reconfiguring so that you lay off some of your nurses or your social workers in order to employ these substance abuse workers. There's no evidence for it. The other two things which I think we have to be very blunt about is 24-hour availability. There is no evidence anywhere in the world that 24-hour availability is either necessary in mental health care for individual teams. Of course, your service has to be available somewhere, but for individual teams, there doesn't. There is no psychiatric equivalent of a heart attack. Nobody is walking along at 12 o'clock at night, feeling perfectly all right, and suddenly becomes depressed. These things, if you have easily accessible services, a 24-hour service, and I must say, I went and looked at all the American ones, almost none of them did it. But they all said they did it. And I said to them, why do you say you do it? They say, if we don't say we do it, we don't get our funding. So when you read about them doing it, stop and think, what can you do at 2 o'clock in the morning with a patient? Very little, really. And on the whole, it's much better to have your staff available during the day. And lastly, this thing about the whole team approach. I feel very strongly about this, but first of all, when I went around the American ACT teams, almost none of them did it. They said, we operate the whole team approach, nobody has a care manager, and then I would go out on visits with the care managers or the case managers, and they'd say, this is my patient, Joe. I said, when you say your patient, what do you mean? He said, I look after him. I said, what about the whole team approach? He said, well, we don't want to upset people, but basically, other people help out, but I look after this person. And I must say, that to me seems humane and sensible. Every one of you in this room got your independence by being able to be dependent on somebody else, whether it was your parents or your partner or whatever it is. All of us achieve our full potential through a healthy dependence that we can then work through and feel good about ourselves. I think to deny it to our patients seems to me utterly illogical. Now, having said all that, I just want to finish with 2 slides to suggest that you can see that I'm a skeptic that this ultra redesign, this high-tech redesign of the team is probably not indicated. And that there can be quite a variety of well-functioning multidisciplinary teams that address the needs of patients well. But I think we have learned some very important things from the ACT research. I think one thing we have certainly learned is that irrespective of the size of the caseload, it needs to be set. Nurses, social workers, doctors need to be able to predict how many patients that they're looking after. And the idea that you just keep adding and adding and adding, I think ACT has helped us stop that. Probably 20 to 25 seems to make sense. We've recognised the regularity of multidisciplinary reviews as a part of routine practice, not just when there's a crisis. And I think the other thing that we've learned is perhaps to be a bit more structured about identifying the level of dependency, the level of need that individual patients do. And this concept of zoning, you know, that you have a whiteboard, and if you have a red tick against the patient's name, that means they need very regular visiting, and if they miss an appointment, you want to go and find out why. You've got amber or yellow for those that are routine, and you've got green for those who are doing very well. So we've learned things from them, from the research. There are some things we've learned nothing about. And I think these are very important things to be thinking about going forward. And I'm just going to finish with this. First of all, I think that we have, because of our fascination with these specialising teams, and the fact that it's easy to reorganise a team. It's not easy to train somebody in complex skills. That takes years, but you can reorganise a team quickly. Because of our fascination with that, I think we've lost a little bit of sight of continuity of care. Continuity of care, every time I talk to a patient, every time I talk to a colleague, every time I talk to myself, I know that continuity of care strikes me as central to good mental health care. To be seen by a friendly face who knows you, knows what it's like when you're ill, knows what it's like when you're well, knows what matters to you. To have that access to a friendly face who knows you, I think is so important. And I think we've overlooked it a bit. And so, for instance, in England, bizarrely, after 40 years of always having the same team look after you when you're an inpatient and an outpatient, which offered, I think, a great deal of reassurance to our patients, we're beginning to break that up because of a fascination with functions and structures. So I think we need to think a bit harder. We know some of the benefits of specialised teams. We need to think a bit harder about what we may lose in it. And along with that, we have to think increasingly about balancing our specialist skills as a doctor, a nurse, psychologist, with our more generic mental health skills, because all of us share probably more than distinguishes us in a mental health team, and that somehow hasn't been given much attention, I think, in the literature. And I put down coercion, paternalism, and confidentiality, because they strike me as the challenges of the future. Our views about coercion, our views about beneficence and paternalism in mental health and autonomy, and particularly, I think now, our views about confidentiality, certainly in the UK, I don't know what it's like in most of Europe, are still determined by thinking that it's 40 years out of date. The world is different. So, for instance, we are taught that if a patient says to you, "You cannot tell my mother that I've stopped taking the medicine," and that mother is looking after him, and she's going to be at risk. Is it, I mean, the world, anyway, I don't have an answer for it, but I'm saying these are, I think, some of the challenges. So I'd like to thank you all for your attention, Magatak, and I'm sorry for so many facts and figures. It gets more exciting from here on in.